So it's a pleasure to have Ken Tyler here today to give ground rounds to us. Ken is the chair of neurology at the University of Colorado, and he has incredible both basic science and clinical expertise in neurovirology, as you already heard earlier today. And I had a funny story to tell about him, but I got some pictures from the AN, but it turned out to be the wrong year. So I said, send me some pictures from the time that we went to the Boston Pops, because Ken and I were both there, and they sent me pictures from 1973. We're old, but we're not that old. So anyway.
I was in kindergarten. I don't know
exactly.
about you. Yeah.
I was in the 4th grade. So let's see. Ken got his AB at Harvard. He did his MD at Hopkins. He did a 3-year internal medicine residency at Brigham and Women's and did his neurology residency at Massachusetts General, followed by a postdoc in neurovirology at Harvard. He's a member of a number of professional societies, advisory committees. He's gotten a bunch of awards. Importantly, he's been the recipient of the S. Weir Mitchell and the Lawrence McHenry Awards from the AAN. He's extensively published in neurovirology, but also you may not know that he's extensively published in the history of neurology, which is sort of an interesting feature. And I also hear that he's an enophile. That gives him something in common with Bruce. So with that, well, I'll let him go ahead and get started. He's going to be talking about emerging viral infections.
I want to thank everybody for inviting me up here. It's been fun to both see the residents and talk with them, see some of our old graduates who are now on your faculty, of course, see Bruce, and the neuroinfectious disease brethren is relatively small, so getting to see Christina is always a treat. I originally, when I was going to do this, thought I was going to be really clever and was going to talk to you about 3 emerging viral infections. One a little bit older, West Nile, one sort of in the middle, enterovirus D68, and one that was just at the time I said I would come and do grand rounds, just beginning to make a little noise called Zika. And of course, as any of you know who get the New York Times or any other newspaper and open it up, I mean, the whole Zika story is sort of exploding. And so I kept on adding slides and realized that unless I was going to keep you here till tomorrow morning, that plan wasn't going to work. So I decided I would just talk to the residents a little bit about the enterovirus D68 Acuteflaccid myelitis story, because it also had a laboratory piece that I wanted them to see, and that I would talk to you guys about sort of the new and the older kid on the block in terms of neurologic flavivirus infections, and sort of spend the time of talking about both Zika and West Nile. And Zika is so new that I got to tell you as a disclaimer that I'm sort of coming up here as a little bit of a sheep in wolf's clothing. We actually have Zika in the laboratory. We just got permission to use it. We've just set up our first experiments with infecting pregnant mice and doing some other things like that. Members of our neuroinfectious disease group, including Dan Pastula, the CDC has borrowed from me and sent to Puerto Rico to set up a Guillain-Barré syndrome and Zika virus surveillance program there before he comes back to us. So there's some connections, including with some of our fellows too. But let's start the story. I'm going to try to watch the clock, and so I'm going to apologize if I speed over some things a little more than others, and we'll see how far we get. Well, Zika takes its name from the Zika Forest, which this sign sits right outside of. It's near Entebbe, about 7 miles away in Uganda. And despite how famous the virus is, the Zika Forest is actually pretty pitiful. It's about 1/3 of a mile by 1 mile long, with some scattered trees like you can see there. If you do a web search, you find that, and they haven't taken this down yet, that it was potentially a nice tourist stop if you liked doing sort of the safari route. Whether they're getting many takers nowadays, I'm not as sure. In the 1940s, the virology research station that I showed you there was a pretty active site of investigation. And the kind of problems they were looking at actually had to do with yellow fever, which was, of course, the sort of prototypic flavivirus infection. And they were trying to understand things like what were natural reservoirs of yellow fever virus, which is an important human virus. And as part of doing that, this guy named G.W. Dick from England ran an experiment in which they set up in that tiny little forest a series of 6 wooden platforms that were at about treetop canopy level. And originally they put rhesus monkeys in cages on 6 of these platforms, separated 500, 800 yards apart through the forest. And nothing really much was happening, and then they got worried that maybe because the monkeys were in cages, that mosquitoes and things weren't biting them. So they took them out of cages and just basically sort of restrained them on the platforms, and they would go and look every day and see if the monkeys had developed any signs of any illness or any fever. And as you can see there, on or about April the 16th of 1947, rhesus monkey 766 developed a fever spike. And the fever developed over the next 2 or 3 days. And on the 3rd of those days, they drew some blood from him and injected it intracerebrally and intraperitoneally into mice. And almost all the intracerebrally injected mice, but none, interestingly, of the intraperitoneally injected mice, became sick. And they became sick with a filterable transmissible agent that they could subsequently isolate from the brains of these mice. And that was Zika. And Dick and his colleagues wrote up the basic characterization of the virus in the early 1950s. And at that time, that was it. I mean, it was kind of like this existed. We didn't even know, or I wasn't around to know, whether this was a human pathogen. And in about 1954, the first case was reported of human Zika infection. And I just pulled it up in the upper corner there. I think you can kind of see. It's fun in some ways reading these old papers. They're not always politically correct, and they get to ramble on a lot more than we do nowadays. But there's a very brief mention in there of an African female, 10 years old, who complained of fever and headache and had a slight fever when it was actually measured. And all this was pretty mild, and within 6 weeks it had completely recovered. And lo and behold, by serologic and virus isolation techniques, turns out she was sort of the first documented human case of Zika. And that illness that she had was pretty typical. Right around the same time, 2 years later, Bearcroft actually did a human inoculation experiment where they took one of the isolates that had been saved from monkey 766, who I told you about before, who became the prototype for Zika, and injected mouse brain inoculum that was diluted subcutaneously into the forearm of a volunteer. Actually turned out the volunteer was a European white male in his 30s, as I remember, although they were not reluctant to do these kind of experiments on the native population, and there was no such thing then as committees reviewing the ethics of experimentation. This was somebody who'd been in the country for about 4 or 5 months, had been immunized with yellow fever virus, as would be common if you were traveling in that area. And I think what you can see here is, this is a little time line here, forget this little coryza. He had a little upper respiratory infection. Day 0 is when they inoculated him with just under 350% lethal doses for a mouse of virus subcutaneously. And then 3-4 days later, he developed a low-grade temperature that got a little worse. And this little cartoon thing here shows that he also developed headache and malaise. And then all of this went away, and he was just fine. They also subjected him to multiple mosquito inoculations because they were trying they exposed him to mosquitoes because they were trying to actually see if he had enough virus in his blood when he got sick that he could transmit to a mosquito, and the mosquito would transmit to something else. So there's even some question as to whether or not the 95 documented blood-engorged female mosquitoes that bit him as part of this experiment at this time contributed to some of that fever. But at any rate, he developed virus. He developed what you see in these upper charts here, both hemagglutination inhibition and neutralizing antibody against both Zika and, interestingly, yellow fever, which I'll come back to a little bit later. But again, proving that the virus could transmit this disease to people. So let's go backwards a little bit. Just, I'm not going to give you a ton of basic virology. I tease the residents a little bit with some of it, but because this is a grand rounds, I want to try to keep it mostly clinical. Zika is what's called a single-stranded RNA virus. It belongs to both the genus and the family Flaviviridae, from which yellow fever gets its name, from the flavi. And that won't probably mean much to most of you. But the part that maybe will is the other viruses belonging to that group include things like West Nile, St. Louis encephalitis virus, Japanese encephalitis, yellow fever, and dengue. These are arboviruses, which isn't an official Latin classification. It means arthropod-borne, and it means that the virus is transmitted by the bite of an arthropod-borne vector, in this case mosquitoes. And the active mosquito for Zika, and you'll hear it's a different one for West Nile in the US, are Aedes species of mosquitoes, notably Aedes aegypti or albopictus. Those mosquitoes were not native to the United States, but now do exist in the United States. And it may be a little hard to see I should have colored it a little bit of a different color. But you can kind of see for Aedes aegypti, a lot of Texas and the southern U.S. Now are inhabited by Aedes aegypti. And the range is a little bit broader. It actually even goes up almost into Pennsylvania and New York for Aedes albopictus. So when people ask, gosh, could this virus, could the mosquito transmission cycle for this virus exist in the U.S.? The answer is yes, it could. The normal cycle for this virus in Africa has been sort of between a variety of different primate species and mosquitoes. And humans are, in a sense, an accidental host in part, meaning they're bitten by one of these infected mosquitoes and can, as you'll hear in a minute, get the disease. But there's something really interesting about this and very different than West Nile. In West Nile, whether you're a human or a horse and you get infected, you can get neurologic disease, as you'll hear, but you don't develop enough virus in the bloodstream to transmit to another mosquito. So you're what's called a dead-end host. So the only way you get human-to-human transmission with something like West Nile is if I transfuse blood, an organ, transplacentally, some mode like that. There isn't a human-mosquito-human cycle. Zika generates enough of a viremia that there is, and that in fact is an important cycle. For all effects and purposes, for most of the other flaviviruses, the overwhelming majority of cases are mosquito transmitted. But some of you may have seen one of the interesting things about Zika is people are trying to figure out a little bit about, well, are any other modes of transmission important? And one of the many hot topics lately is the recognition that there can be sexual transmission of the disease. One of the cases was actually in Colorado that was first reported, where a physician who came back and had been infected in an endemic area transmitted infection clearly to his wife, who was a nurse, through sexual contact. She had not been exposed in any other way, and there's subsequently been other documentation of that. And of course, it brings up all sorts of interesting questions that we don't know the answer to. What we do know is you can detect this virus in semen, and you can detect it in pretty high titers. What we don't know is, hey, is that an important epidemiologic mode of transmission? Is it just just male to female sex? What about male to male sex? What about female to male or other sex? How long do you shed this virus for? How long might you be infectious? All the documented cases so far have been in symptomatic males. So it's probably not politically correct, but I have to admit when I read some of these cases, I'm sort of impressed that a guy can have a fever, arthralgia, a rash, and joint pain, still okay, wants to have sex. Whether or not asymptomatic individuals would transmit the disease, we don't know. If you go backwards, I started the story in Africa. There was really just sporadic cases of Zika that didn't really get very much attention until about 2007, when there was a big outbreak in a small island in Micronesia called Yap, where I think their population is around 7,000 or 8,000, and literally a third of the individuals on the island got infected with Zika. And then there were a subsequent series of outbreaks in the tens of thousands of cases in several French Polynesian islands. And for the first time, there were some odd reports of some neurologic syndromes, mostly Guillain-Barré, and we'll come back to that later, with the sudden spike in the number of GBS cases coincident with these Zika outbreaks. And just to put this in perspective, we don't know what the number in Brazil and South America is now, but the range of estimates is probably a minimum of 500,000 people and up into the 1.5, 2 million or more. So far and away, the stuff that you've been reading about lately is the biggest outbreak. We don't know how it got to Brazil. There's been a lot of speculation that there was a lot of travel right before this happened for some big athletic events, including the FIFA World Cup and some international boat and canoe racing, but nobody knows for sure. And then I'm going to come back to some of the rest of what's on that slide. This kind of a map changes almost week by week, but kind of shows you a kind of quasi-list of countries that have reported Zika virus infection with endogenous local transmission. I'm going to show you the US in a second. So when Donald Trump builds his wall, we'll have to see whether the mosquitoes would move north or people would move north. We don't know that yet. As of about a week ago, they've been updating it about every week or 2 weeks. There have been 153 Zika cases in the continental United States. I marked every state there with a number that had reported 5 or more cases, and any state in blue is anywhere from 1 to 4 cases. Washington has had either one for sure and probably a second one. There's some ambiguity. The CDC, I don't think, has officially confirmed that. All of the cases reported in the continental United States so far have been cases who acquired the disease overseas in an endemic area. There have been 107 cases in Puerto Rico, the U.S. Virgin Islands, and American Samoa, U.S. territories. And all of those are the result of local transmission, meaning the 102 Puerto Rican cases were all acquired in Puerto Rico. Those are not imported cases. So the virus is already endogenously circulating there, in the U.S. Virgin Islands, and in some U.S. territories. Obviously, many of the areas on that map are popular tourist attractions, especially during the winter, so huge numbers of people have potentially been exposed. There's been a lot of panic, and people who traveled and were pregnant to those areas seeking Zika testing, and a subset of those people have in fact tested positive, and we'll talk more about that in a second too. So what is the disease as we kind of thought we knew it now? Well, like for many of these arboviruses, and you're going to hear the same story when I talk about West Nile, 80% or so of people who are infected are totally asymptomatic, meaning we would diagnose your infection by serology. 20% or so are symptomatic, and typically in the first week after being bitten by a mosquito, they develop an illness that typically has features that include fever, rash, joint pain, headache, conjunctivitis, muscle aching. It's usually pretty self-limited and not particularly severe, and disappears after about a week. And as you see there, disease requiring hospitalization uncommon, case fatality low, and we'll talk about the bottom of that slide in a minute. This was a mini review sort of by Duffy and colleagues that came out about 5 years ago in the New England Journal, describing the characteristics, as I told you, of that big first outbreak on the island of Yap. And pretty much was what I said. It just gives you some percentages from 90% with the rash, 65 or so percent for fever and arthralgia, conjunctivitis a little less, and running down to the bottom. This is sort of what the rash looks like. Not having spent as much time in dermatology as I should have, all rashes have a certain similarity to me, and I would have just called this a maculopapular rash. And you can see a little bit, sometimes this is less common. This one sort of has a little bit of a malar distribution, so it's not always as dramatic. Obviously, I tried to pick some illustrations of pictures that showed it up a little bit better. The conjunctivitis is typically fairly mild. This is a more severe one, just to give you a sense of it, but you can see there's mild conjunctival injection here, and boy, that's pretty subtle. And I can see it maybe a little better on my screen than perhaps you can. This one I just put in here because it's the eye, but you can get eye involvement in the congenital cases. Here's the optic disc showing some pallor. It's a little hard for you to tell without a good color scale here, and one of these big chorioretinal lesions. You don't see that in the adult acute infection. That's from a baby, and we'll come back from that later. One of the problems in these areas is there are a number of other viruses circulating, notably dengue and to a certain extent chikungunya, that pretty much I could have told you an awful lot of what I just told you about in terms of the clinical syndrome, that they have fever, rash, a little less likely to have conjunctivitis. You can see there are 2 pluses here versus the none in the others. Arthralgia, myalgia, headache. You don't see, for those of you that are dengue aficionados, so far the dengue hemorrhagic fever or shock syndrome. But clinically, it would be very hard to distinguish these. I think a lot of the attention would never have happened if the story ended where I just ended it there for you a little bit. This is actually a much milder illness than, say, chikungunya, which we haven't paid a huge amount of attention to, despite the fact that millions of people around the world have gotten infected, and it produces a pretty horrible arthralgia and pain syndrome. But there started to be these reports, notably from Brazil, and a little bit even geographically spread in Brazil toward the kind of northeastern part of the country, of an increase in reported cases of microcephaly. And it's just shown on this. I think this one was from the World Health Organization or the Pan American Health Organization. This was kind of an incidence rate per 1,000 live births of the historic kind of incidence of microcephaly. And then this was microcephaly as it had been reported in 2015, and I think you can see this big explosion of bigger purple circles. And most people were saying, God, this is a 20 to 50-fold increase in number of cases. There were over 5,000 reported, not all of those linked at all to Zika, but something seemed to be going on. It's very hard, and this is all very new, to get a real feel of the epidemiology. And so I have to warn you that there are probably some things that I'm going to tell you that we think we know that we actually don't know, or that are going to be wrong. And every day you turn around, there's something new on this. One study of about 88, I think you can see the number up in the top there, symptomatic women who had a clinical illness consistent with Zika who were pregnant, was done in Rio, and about 28% of those women had fetal abnormalities. So an incidence of about 1 in 3 if you had symptomatic Zika infection during pregnancy. The most dramatic of the live birth abnormalities were microcephaly, and again, it's really moving. You can go on the web and see literally hundreds of pictures of, babies with this kind of, depressed and sloping back forehead and small, more than 2 standard deviation removed head circumference abnormalities, often with other neurologic abnormalities too, including blindness or visual impairment, retinitis, hearing problems, seizures, developmental delays. We still don't completely, understand what the spectrum is going to be of that disorder. In the study that that I was just quoting to you by Brazil and colleagues from the New England Journal, one of the other things that was very interesting is they looked at their patients who had abnormal findings as illustrated in the sort of purple or really dark blue bars here. And the only point I sort of want to make is this is when in gestation they had their symptomatic Zika infection. And the point is it isn't really clustered per se in any part of the spectrum. So it actually looks like abnormalities can occur whether you're infected in first, second, or third trimester. And it's going to be interesting to understand a little bit, are there differences in the frequency with which that happens? And as you might predict, are there going to be differences based on neural development in the clinical syndromes, which is just what we see with cytomegalovirus. So cytomegalovirus, if you're infected during pregnancy, the likelihood of fetal involvement goes up in succeeding trimesters, but the severity of the neurologic complications actually gets less. Worse to get infected but less common to have fetal infection in first, say, versus third trimester. We don't know how that's going to play out for Zika. If the kids are born and you do CT or MRI, you sort of can see findings like these multiple calcifications, enlarged ventricles, atrophy. Here you can see this tremendous ventricular enlargement. You can detect some of this in utero by ultrasound. One of the problems, though, in the reported cases, and the numbers are still small, is it may not be until very late in gestation, think 25 weeks or more, 26, 27, that you see abnormalities, and often early ultrasounds just don't, 12 weeks, 14 weeks, 16 weeks don't really show much of anything. When they do, occasionally you can make out ventricular enlargement or calcification or other things like that. Roberta DiBiase, one of my old fellows, who's now the chief of pediatric infectious disease at the Children's National Medical Center, sent me this, and this will be coming out shortly in the New England Journal in a paper from an American woman who had a Zika infection while in Brazil and had a initially normal series of ultrasounds. They did at about 19 weeks gestation. They have pretty impressive ability to do intrauterine MRI studies. And here in this panel on this right-hand side is what a normal, roughly 20 weeks gestation brain MRI of a fetus would look like. And I think what you can kind of see here is, again, tremendous ventricular enlargement in the Zika infected from this woman, thinning of the cortical mantle, and they measured it, I think it's 1.4 millimeters versus a normal about 8. You can also see there's some abnormalities in the third ventricle here, and probably agenesis of the corpus callosum as well. This woman elected to have a late pregnancy termination, and this is the brain of the first of the cases that was reported. There'll be a second one coming out shortly. And I think you can see in this case, which is actually from a paper preceding the one I just showed you the MRI from, this massive simplification of the gyral pattern. It's a little hard for you guys to see, but there's some foci of calcification where these arrowheads are. This funny, ill-developed ventricular system. If you look pathologically, there's this calcification, which usually is a sign of bad injury to neurons. So they're pointing out these kind of calcium-encrusted neurons with all of this degeneration. And electron microscopy showed viral particles consistent with Flavivirus. Yeah.
Did you say when in her pregnancy she was?
13, I think she was 13 weeks. There's sort of two. What's happening now, if you look at the New England Journal, it's yet another case report. I mean, not inappropriately, I mean, just they aren't really big series. And Roberta's patient, I think, was infected at 13 weeks. One of the other ones was around 19 weeks, I think. So, and again, these are just sort of the single case reports. What's going on? We don't know. But some of you may have seen there was a paper that just came out in Cell Stem Cell from a combination of people, but part of the group was at Hopkins, where they looked at human neuroprogenitor cells and infected, induced pluripotential stem cells into neuronal progenitor cells and infected them with Zika. And that's what's shown in the bar graph here, that embryonal stromal cells, the precursor stem cells, not particularly infectable with virus, then these bigger bumps here, two different lines of these human neuronal progenitor cells, and mature or more mature neuronal cultures not really infectable. So they sort of were trying to make the case that there may be something about neurons in early developmental stages that remains to be confirmed that are more susceptible to infection. And what they're showing you here is just Zika virus staining with an antibody against the viral envelope glycoprotein. So all the cells that are in green are infected, and that's just shown in higher magnification here. And interestingly, they suggested that the mechanism of neuronal cell death was probably apoptosis. And they did this by looking for staining for activated caspase-3, the effector caspase. So remember that whether you come down through a cell surface death receptor pathway or a mitochondrial pathway, you converge on caspase-3. So there may be infection of certain sets of neurons and apoptotic death. We don't have a treatment for this, but in case any of you were wondering, I think the Pope said contraception was not always a deadly sin, so I'm sure many of you in the room will be glad to now know that there are exceptions. In addition to the microcephaly story, the next one that sort of started to emerge is a GBS story. And that originally really came out of the French Polynesian infection experience that I alluded to before Brazil. Many South American countries have now been reporting the spike in number of cases of GBS, but again, the epidemiology here is not ironclad. And the basic model here is people who had a pretty classic Zika syndrome and then developed a Guillain-Barré-like illness. And usually the tip-off has been both, hey, especially in an area where Zika didn't exist before it was introduced, and the temporal clustering. And I think at the bottom there, I just allude to the fact that there were all these, kind of massive increases in reporting, just like we said for microcephaly, of GBS in some of the affected areas. This is from the French Polynesia outbreak, and here, this is from this paper in The Lancet that just came out a few weeks ago. And here you see sort of the epidemiology curve in 2013 and 2014 for their Zika cases, and sort of, to me it looks pink, I guess I'm not sure what color it looks like to you. And then the darker bars shifted a little bit rightward from the Zika bars, where their surge in cases of Guillain-Barré, and I think it was a total of in the 40s during this brief period of time. I won't go through, this is just some of the charts from that paper, all the details of this. For the aficionados, Jane or others, it looked like this was the AMAN, the acute motor axonal neuropathy type of Guillain-Barré, meaning they didn't see dramatic changes in conduction velocities. It really looked like much more what we had seen in China and often seen association with Campylobacter jejuni. Most of those cases, the pathogenesis has been linked to molecular mimicry, like in the case of Campylobacter jejuni. You probably make antibodies against the virus, against the bacteria. Those antibodies cross-react with gangliosides that are present on nerves. It may be that happens here, but at least screening for antibodies against gangliosides in that small subset of about 42 patients, there wasn't a dramatic smoking gun. So the mechanism isn't clear. It is still sort of a coincidence epidemiology link. This is probably one of the few kinds of talks that you give that you're actually on the United flight coming out to from Denver to Seattle, paying your $6.99 to do Wi-Fi and trying to figure out, holy crap, has something happened that I should tell them about, Sort of the two latest things are, there's now been a report of acute myelitis in, I think this was a 15-year-old. I'm sorry, I can't remember exactly, which I just pulled this from, that was clearly linked to Zika. And in this case, they actually amplified the virus from the spinal fluid. And this is a New England Journal thing from, I think, the 3rd of March. Of a case in an older man, I think he was 81 or something like that, of what looked like meningoencephalitis clinically, again with isolation by PCR of viral genome. So the only reason I'm even bringing these up is we sort of have kind of seen this movement where you had a virus that wasn't even clear it was a human virus, then sort of made mild illness, and then as we got bigger case numbers, you started to see some things like Guillain-Barré and other things. Probably the risk, even in, if you go backwards and try to look at it, Guillain-Barré was a rare complication of an event, so you needed a big enough N to start to see it. Then all of a sudden you're getting potentially microcephaly, and we don't know it caused all those cases, but we do know you can find the virus in amniotic fluid. We know you can find it in the brain of these pregnancies when they're terminated. We do know there's some biology behind it. And now you're starting to get some of these other things, and it'll be interesting to see which of these pan out, how common are they, but I think we're just beginning to see this story emerge.
Ken, can I ask you just one
Yeah.
question before you leave that slide? For a completely benign virus that has no neurologic complications, would you expect to see it in these same fluids?
No, not typically. So I'm thinking back to historically, when we were sort of playing with things like PCR for herpes simplex virus, and pretty much you don't randomly see viruses in amplifiable genome of viruses in the CSF when you do these PCRs. And so even if you have a non-neurologic infection, you don't usually amplify these viruses. And I have to be very careful when I say that, because the bullshit part of that is one of the things we've sort of learned is, viruses are, there isn't a generic virus, and I'm just trying to think about flaviviruses and other things. So we used to tap a lot of people with West Nile when they complained, of course, of a headache, and it was part of the West Nile fever syndrome. You didn't amplify acutely, virus from CSF. So. But the critical part behind your question, which I think is important, is, an N of 1 doesn't mean anything. And it's just, I think it's interesting. The two things that are intriguing to me are that these are starting to appear, and which of them are going to appear and which aren't. And the second little one, which I'm a little cynical about, is who would have thought that a simple case report, often with the degree of documentation that these have, would be, Lancet's falling all over themselves, the New England Journal is too, and there's a little window, like that. And but I should, people in glass houses shouldn't throw stones. So when, the first PML cases with Sabri were reported, we had one of those, and it was just a case report. And, the New England Journal printed back to back to back 3 case reports of PML associated with Sabri. And the situation was weird enough that the case report seemed to be a sentinel event, and in that case it actually was. Whether any of these will be, we don't know. Microcephaly has legs, and GBS has legs. The rest of this I don't think we know. So it's sort of fun to contrast one we do know more about for the parts that are the same and the parts that are different. And I'm going to blow through this one a little quicker because I'm watching the time here. But basically, West Nile, another flavivirus, closely related and isolated 10 years earlier from the same country. It was 1937 instead of 1947. And West Nile is in Uganda, not too far from, not exactly next to, but from Zika. Since the virus was introduced, there have probably been about 45,000 documented cases, obviously many more that exist, but those are CDC confirmed cases, just shy of 20,000 neuroinvasive disease cases, about 2,000 deaths. For most of these viruses, like I alluded to, there's about 150 or 200 people infected for every case of neuroinvasive or encephalitic disease. So probably in the order of 3 or 4 million people in the U.S. have been infected with West Nile since the virus was introduced. Started on the East Coast, rolled across the country, but if you look at a 15-year overlap incidence map, you can see that most of the cases are sort of been concentrated in the central part of the U.S. You can see dark black here is about 2 cases per 100,000 population per year. Herpes simplex is not a reportable encephalitis disease, but the number we usually use for that is about 4 per million population, so 1 per 250,000. So it would be, somewhere in this pale blue, but all over the country. So to just give you an idea of how important it is. 2015 was an average season with something over 2,000 cases. And again, the map looks pretty similar to the compiled map that I showed you. I'm not sure whether it's we're allowed to say that it's a cool feature or not, but shortly after the West Nile epidemic started occurring, you could really probably for the first time almost get encephalitis information in real time. So you could go every week to the CDC's website and they'd be updating case counts by state. You could, and you still can do this, you can link out of the CDC's website to the U.S. Geologic Surveys website, and there is a map of the U.S., a list of viruses across the top, including West Nile. You can click on a virus, you can click on a state, you can get a map, and I just pulled up the West Nile one that looks like this, where at a county level in relatively real time, they show you the number of cases, where they occurred, what season of the year they were occurring in. So of your 79 West Nile virus cases, and in the last 10 years, this happened to be the data for the cases that appeared in 2015, which was, as I recall, 16 and about 8 neurologic ones, just where they were located. Must have been a little more than that, just counting up the numbers. But it's very interesting that you can get this data in this way. Unlike herpes, in the U.S., because this is an arthropod transmitted virus, it has a very sharp seasonal incidence. So in the U.S., the peak of cases are typically in mid-August. They start in May or June. As you start in most states, including Colorado and you guys too, to get the cooler weather in September and October, mosquitoes less active, less biting, disease tails off. I showed you this kind of a figure for Zika. In the case of West Nile, the reservoir of the U.S. is birds, so it cycles basically in a mosquito-bird reservoir. If you get bitten by an infected mosquito, or if a horse gets bitten, you get the disease. But notice there's no cycle that now shows horse or human mosquito and that same animal again. We're dead-end hosts. Why is that true? That's true because the level of viremia you get in a person isn't really high enough in the case of West Nile to infect a biting mosquito, whereas in the case of Zika it is. The birds are remarkable. It is certain species more than others. I don't know if we have any ornithologists in here, but it's basically passerine species, so think robins, jays, grackles, crows, finches, and sparrows. They can replicate the virus to extraordinary titers, so don't pay attention to all the little dirty curves through here, but just look at this big black one. So this is time across the bottom on the x-axis. This is a log scale across the y-axis. So some species of passerine birds will generate viremias up to 10 to the 10th power plaque-forming units of virus in a milliliter of serum and hold that level for a week. And that's extraordinary. I mean, usually to get those kind of titers of a virus, we have to do a density gradient centrifugation with cesium chloride and pull out the band to get something like that. The bird does it easily all the time. So you can see why if you bite them, you're going to get infected if you're a mosquito. I also taught you a little bit about the Aedes species of mosquitoes. For West Nile, it's mostly Culex species, so it's a different species. And where we are and sort of where you are, it's mostly Culex tarsalis. In other parts of the country, it's other Culex species. But interestingly, West Nile is pretty promiscuous, and that may have enabled it to stay around for a long time. So more than a third of the tested mosquito species are at least infectable by West Nile in a laboratory environment, and a pretty good number of them you can find virus in wild isolation. So that it's pretty adaptive, but the key transmitters are Culex mosquitoes. As I said, I showed you sort of this in words before, but this is the classic CDC kind of iceberg pyramid for this. So 100 people infected, 80 show nothing, 20 show a bad febrile illness, 1 shows some form of neuroinvasive disease, which you can somewhat artificially characterize as encephalitis, meningitis, or a polio-like illness. Obviously, they aren't discrete. And there's a certain artificiality to that. We've known for a long time that one of the risk factors behind neuroinvasive disease, notably encephalitis, is age. And so you can kind of see here this increasing incidence of the neuroinvasive disease per 100,000 population with increasing age. And from a practical point of view, almost all the encephalitis cases turn out to be in people over 50 and more typically over 60. And conversely, it's relatively unusual, not unheard of, not unreported, to see pediatric neurologic West Nile. Roberta, when she was working with me, tried to collect up all our pediatric cases in Colorado, and you can find examples of everything, but it was relatively unusual. Let me just make one other point off this. There have been now a number of these GWAS studies looking to see if you can find other linkages, genome-wide association studies, either that seem to be susceptibility markers for West Nile or susceptibility markers for disease severity. And I used to show a bunch of slides for a lot of them, but I've become a little more careful about GWAS data in small populations now. But I will tell you that there's a literature out there that links susceptibility to West Nile and to severe West Nile with things that make sense, mostly components of innate immunity, mostly interferon-associated genes, but a few other genes as well. And they make sense in animal models. So when we put a West Nile into, say, a mouse lacking an interferon receptor, he gets much sicker and much worse disease, and a bunch of these others. But they're such small-scale studies, and the second study doesn't always replicate the first. And you know the problems sometimes even looking when you have much bigger case numbers. But it's an interesting area of investigation. So what's the actual disease? I'm focusing mostly on the yellow stuff here. So obviously, like if you think about the encephalitis, altered mental status, a set of movement disorders, including tremor, which can be Parkinsonian at rest or more of an action or intention tremor, true Parkinsonian features with bradykinesia and rigidity and postural instability, myoclonus, all seen in variable percentages and in different little reports depending on who described what. The numbers differ. A pretty typical weakness is common, and we'll talk about that a little bit more because it's a lower motor neuron pattern of weakness and it results from spinal involvement. A collection of cranial nerve abnormalities, including facial weakness, but also vestibular, eye, and others. The parts of this that are weird and unusual is most of the acute viral syndromes that we see clinically don't have these Parkinsonian features. They don't have myoclonus. I mean, obviously, some non-viral things do. And this very unusual pattern of weakness, which is clearly, as you're going to see, a myelitis. If you do MRIs on these patients, consistent with the story I told you, when you see abnormalities, they tend to develop over time. They may not be present initially, and when they are present, they're sort of in deep gray areas. Think basal ganglia, thalamus. Look how beautiful that is in the substantia nigra. I just pulled this from a CPC from the Annals of Internal Medicine, but we have ones that look exactly like this. And of course would make you understand, well, if you have lesions like this, I can understand how somebody can get Parkinsonian syndromes. This would almost to me be the mirror image of herpes. So if I was showing you an MRI of somebody with herpes encephalitis, remember, what are we talking about? Orbital, frontal, temporal, not the deep stuff. And that's in part helps explain some of the differences in the symptomatology.
And very focal with herpes, right?
Yeah.
Terribly asymmetric. This looks
Right.
perfectly symmetric.
So herpes can be funny. So you can see, of course, very asymmetric lesions. And, as you know, in the old days before we had great imaging, I mean, there'd be the case reports of somebody would think it was a tumor or something because it would be such dramatic swelling of one temporal lobe. But you can get symmetric ones, limbic encephalitis too. And we don't always, these are generally symmetric. It's I hadn't actually thought about it. So now I'm going to have to think about it during the rest of the rounds, how asymmetric have been the ones that I've seen. But my quick mental image of MRIs is that they usually are symmetric, not always equal, but at least not just unilateral usually. So I'll think some more about that in a second. Pleocytosis. Order of magnitude, this is from 250 spinal fluids or something we looked at some years ago. 200 plus cells. A normal glucose, mildly elevated to moderately elevated protein, more with encephalitis than meningitis, say 100 or so versus 76 in the meningitis. One of the weird things about this is I always, when we try to box things into how do I remember or think about things, the usual pattern, if I say virus, is you should say lymphocytic pleocytosis with normal sugar. And if you're really smart, you might think of some of the exceptions where the sugar isn't normal, in the same way that the classic profile for bacterial meningitis is polys and a low sugar. Well, West Nile breaks the rule because often they have polys, often there's a lot of them, and often they persist. 2/3 of the cases are still lymphocytic predominant, but we and others, pointed out often there are polys and they last. They don't just flip over into lymphocytes within 24 hours. So again, if someone tells me about an aseptic meningitis cases and there's polys and a normal sugar and a negative gram stain, for us, and it's the right season, I'm quickly thinking about, could that be West Nile? And you'd never see 50% polys and persisting polys in herpes encephalitis, for example. The spinal fluid can be very, very reactive. I just picked this one because it's kind of fun from one of our patients. So you can see kind of polys, you can see cells that look like plasma cells, you can see these giant molare type mononuclear cells, and there have been case reports and reports of, plasma cell pleocytosis as a clue to West Nile or molare cells in West Nile. I don't think any of those are very sensitive or specific, but I just want to make the point that this is a very reactive looking spinal fluid. In 2 slides, I think I just want to talk about this acute flaccid paralysis form of the disease because we recognized very quickly that there was a subset of patients who developed really a polio-like illness. And some of you who were here for the enterovirus D68 talk, heard me talk a little bit about that as a poliomyelitis-like illness, where they developed this very rapid progression of a lower motor neuron type weakness. Could be one limb, two limbs, three or four, absent or decreased reflexes, preserved sensation, often bulbar and sometimes respiratory involvement. And those of you that are really interested in this may vaguely remember that when Guillain-Barré was introduced, when West Nile was introduced to the United States in 1999 in New York, some very astute doctors spotted something odd, but what they thought they were seeing was an epidemic of Guillain-Barré in older individuals in the Bronx. It wasn't Guillain-Barré. It turns out it was West Nile, but there was nothing wrong with the way they were, with the way they were thinking. CSF pleocytosis, the electrophysiology is consistent with a motor neuron or anterior root process. So all the sensory neural action potentials and amplitudes are preserved. The conduction velocities are preserved. It's the motor amplitudes that decline. In many, but not all of those patients, you'll see MRI abnormalities that look like this with increased T2 and flare signal in the spinal cord. And if they die, we have a big, like you guys do, transplant population, and one of the first groups of patients with West Nile that I got interested in and wrote up because they were sort of like the human equivalent of mice with immunologic knockouts, was West Nile as it occurred in transplant recipients, including liver transplant, notably, was a big collection of our series. And as you can imagine, they get horrible disease. The outcomes are not good. They die. There's a lot of pathology we had. And here's just an example of one of the patients with this polio-like syndrome and also an encephalitis, actually. And you can almost see that the motor neurons are totally gone. It's like someone has just, erased them. How do we diagnose this? It's not as easy as they're wearing the Tutankhamun mask. It's serology. And I want to come back to this point. So basically, we don't use PCR to diagnose West Nile because typically the CSF PCR is negative at the time the patients are presenting. The exception may be immunocompromised patients. Christina asked a question about enterovirus D68 and why the PCRs were negative. And it's interesting, they're negative in things like West Nile too. If you get them in the blood and you get them early, they're positive. So the diagnosis is serologic. And it's detection of IgM antibodies in the spinal fluid. And remember, IgM is a relatively big molecule, so pretty much doesn't cross the blood-brain barrier easily. So if you find it in the CSF, it typically means it was made intrathecally, and it typically means the antigen is there. And that's how we diagnose it. You subsequently develop IgG antibodies. Those persist for life and are protective. You don't get West Nile again. Interestingly and weirdly, in a subset of patients, the IgM doesn't go away after 2 or 3 months, but can persist. But that's another story and another theme. One of the conundrums for Zika that I didn't talk about, but this reminds me of, is this issue of the fact that when you get infected with one flavivirus, you often make antibodies against closely related viruses. It's a heterologous antibody response. And the way we sometimes have to distinguish which was the flavivirus you were infected with is by looking at things like, in general, you make a higher antibody response against the virus that infected you versus its relatives. And if you actually can measure neutralizing antibody, not just do an ELISA, meaning have a cell culture equivalent model where you're mixing serum and virus together, then inoculating them down on a susceptible monolayer of cells, so you're looking at the ability of an antibody to neutralize the virus. The neutralizing antibody titers are almost invariably higher against the inciting virus than against any of its cousins. But one of the problems they've had to deal with is PCR usually negative in these Zika cases, except acutely. Serology, good. But if I develop an IgM antibody response in an area where dengue is endemic, where chikungunya has appeared, where there's other viruses exist, it can be tricky sorting co-circulating viruses around, and that's been one of the problems in the epidemiology. Not an issue so much for West Nile. No active effective therapy. So this looks like, one of those family weekend to-do lists, get rid of clean the roof gutters, remove the tires, get rid of standing water, don't go outside, cover yourself up, use lots of DEET. Nobody ever does it, including during epidemics, but it does actually work. So if you're not bitten in this case, you're not going to get the disease. The data on actual therapies is pretty pitiful. No antiviral known to work. Insufficient data to make much of a comment about a role for steroids or even interferon preparations like Alpharon, mostly just anecdotal. One good trial that they tried to get going and ended in 2007 using an IVIG preparation from Israel called Omri IgG-AM. They never published, we were one of the biggest enrollers in the trial, the full details of the study, but they published bits and pieces of it. It didn't seem to show efficacy, but there were lots of flaws in the study design, so you're not sure, was the long entry period that you could enroll patients and other things biasing against efficacy of the treatment, but we just don't know. If you're a horse, and we have crap loads of horses out in Colorado, we already have, it's either 3 or 4, I always forget, licensed vaccines against West Nile that are all effective. If you're a horse, we sell it for about $20 a dose, and if you buy enough doses, you get a free saddle blanket. And I just mention it to say there's no intellectual barrier against developing an effective West Nile vaccine in human. In fact, many of the things they put into horses are the exact same vaccine they began phase 1 and phase 2 trials of in humans. They just have never moved into phase 3, mostly for economic reasons. And again, just to remind you that for Japanese encephalitis virus and yellow fever, 2 related viruses, we have effective human vaccines. I'll skip that one. So lots of people obviously involved at different stages of this, depending on which parts of the story. Why don't I stop there? And if people want to ask questions, I'm happy to stick around for those. But thank you very much.
Is there any cross protection? So if I've been yellow fever vaccinated, can I go where we go?
No. So actually, interestingly, the paper that the group at the Children's National Medical Center is going to show of their woman, American citizen who got infected, had been vaccinated. She was from a family that traveled extensively, and she'd been vaccinated against both Japanese encephalitis and yellow fever, and yet still got clinical Zika and still had an infected fetus during pregnancy. So, no. One of the coolest things I ever did with West Nile, being a city boy, was that when it was happening a lot, I got a call from some farmer out, actually a veterinarian in Colorado, who asked me, did I want to see West Nile and horses? So I said, sure. And I got my blue jeans, bought a pair of cowboy boots, got a cowboy hat, and drove out to western Colorado. And he brought me out to some field. It was like something out of the movies. And the horses are running around, and he's pointing out which ones have West Nile and how. That one is ataxia, that one is facial weakness. And they had a vaccine. So he asked me, so if I accidentally fell on the needle from this $20 vaccine that we're giving to all our horses, would I protect myself? The answer is he probably would have. But no, your other vaccines won't protect you against Zika.
Are they working on a Zika vaccine? And is there a way to do vaccines and keep them in cold storage or something for an eventual disaster that could hit?
Yeah, so most of the stories have sort of said we're probably several years away from a Zika vaccine, but there have been some proposals to sort of fast track it based on, we know an awful lot about these vaccines related to Japanese encephalitis and yellow fever, and there have been some of these what are called chimeric vaccines, where you basically take the genome of one of these viruses and stick in a key protein from another virus, and so you're basically using the base of a vaccine that you know is safe. And so there have been some thoughts that maybe with some of these techniques, you could get to this much faster. The West Nile problem is a really instructive one. A lot of the companies that were pretty aggressively pursuing therapeutics and things for West Nile just decided they didn't see an economically viable pathway to do this. Not enough cases. Who would you vaccinate? You know, sometimes it's a lot, sometimes it isn't. How are we going to make money on this? And now you can imagine some of the parts of the world where this is occurring, you know, there's economic and other challenges. So it'll be really interesting to see how to do it. If you have it, you can, of course, stockpile these vaccines and then, you know, if you had an effective vaccine, and you could roll it out in a, you know, an emergent situation.
If there were a vaccine.
Yeah.
And the woman was vaccinated before she became pregnant and was in the Zika endemic area, would baby be protected?
Yeah, probably, because the core infection would be in the woman. Most of the evidence would suggest what happens is it's the maternal infection, viremia, placental involvement, and there is evidence of virus in a few cases in both amniotic fluid and pathology in the placenta, so that's the route of spread. Almost all of these vaccines prevent viremia in challenged people, so there would be a very good chance, thinking of other models and things, that you would not develop significant infection in the mother, ergo unlikely to get the fetal infection. Again, this is informed speculation, but based on what we know about these, others. And it might depend a little bit on the what type of a vaccine do you use too. But Kate, and then
Oh no, please.
I've read that one of the reasons for the epidemic is thought to be global warming, that the mosquitoes are infectious at the very end of their life, and that the virus is maturing more rapidly in them because they're warmer. Is that true, or?
So there's been a lot of speculation about how global warming is changing things related to infectious diseases. Obviously, it's changing habitats of where mosquitoes are and can, thrive, and that those boundaries of areas, because often they are regulated by things like temperature and other things. And you're also right scientifically that in many of these models, within a narrow band, often things like many viruses have temperature sensitivity bands, is I guess what I was sort of awkwardly trying to say, and there is a range where often replication increases as temperature increases up to a certain point, and then of course you get heat inactivation too. So interesting speculation, but like the same problem you have with attributing specific climatic events, to global warming is, hey, there's a plausible biology, but that's not the same as saying it caused that hurricane or that thing. But it's really interesting, and people have been really interested in how is it changing where the vectors are and the birds that, and the natural animals that they thrive on. And then, as you say, there would, in theory, might be some other, I think those would be the more likely impactful ways, because remember, your body temperature doesn't really change with the outdoors temperature within certain bands if you're a mammal. That's not as true for, of course, non-mammalian species, which are more, the external temperature does affect them and therefore could affect things replicating in them.
So Ken, absolutely terrific lecture. I've canceled your plane reservation for tomorrow so you can stay and talk a little bit more with us about these fascinating topics. The biology of the reservoirs, the animal reservoirs, is hugely interesting and often sort of given slight attention. You did a great job of highlighting that, but it leaves further questions. What makes a particular kind of bird so capable of tolerating spectacular virus loads? You showed us a dead bird, so I presume that's not a good thing for birds in general, or is it okay? And if it's okay, how is it okay?
Yeah, so these are great, and it's a whole series of great linked questions. In some of these cases, and maybe those monkeys and things on the platforms are an example of that, natural reservoir involves a species that's hardly affected at all by the infection. So everybody kind of wins. The monkey doesn't die. You can, it can go on and reproduce and do other things like that. In other cases, that's not true. And for some of these bird species, they die. And that one that I actually showed you a picture of was, I used to walk to work. It was about 12 blocks from my house to where the old hospital was. And in 2003, when we had our big epidemic, you would walk into work, it was like being in an Alfred Hitchcock movie. There were dead birds littering the street. That one was on our front lawn. So I photographed it and then had my wife get rid of it, so.
What is the likelihood that there are other reservoirs that we don't know about yet?
Almost certain. Actually, if you do, although it's a little bit weird, if you go back and look at those early papers from like the 1950s, one of the first things they did was, hey, we're trying to isolate virus, and they stuck it in bunches of different animals. So they stuck it in mice, and they were susceptible, but there were root and age-related factors. They stuck it in guinea pigs and weren't so sure. They stuck it in rabbits, didn't get anything. They stuck it in monkeys, did, of course, get a little bit of fever and things. So in many of these cases, there isn't just a single mammalian species. There's a broad reservoir. And sometimes about the closest you can get to even understanding what that is by doing serosurveys. Instead of saying what species of animals do you see antibody in, which at least means that they could be infected. And often when you do that, you get really broad, things. It's a different virus, but I started doing some work with a virus years ago called reovirus because it was an animal model. I used to write one of these textbook chapters, and I'd write some sentence at the beginning of one of the sections where I'd say, and antibodies have been detected in. And at one point, I just had to say 107 different species because literally the more people looked, the more people found antibodies suggesting they could be infected. But whether they're part of the critical cycle, either to maintain the virus or as a source of, the mosquitoes that bite the humans, is a more complicated question.
So then, based on everything that we don't know about the hosts, the vectors, the reservoir, the transmissibility,
I have a good future.
you, but also the Olympics.
Yeah, so that's been a year.
Where on the pandemic curve are we? How much do we need to know before we?
Yeah, so what I didn't show you in the Zika talk, because it's almost there outdated instantly, but I should probably, you gave me an excuse to mention it, is the CDC and the World Health Organization and the Pan American Health Organization have pretty regularly been producing algorithms for what do you do if you have a pregnant woman coming back from one of these areas. What would be the current suggested workup? A woman with potentially microcephalic child. These are changing, so I'm not sure that it was really informative to do that. But there's been a lot of controversy over, of course, as I said before, the equivalent to the West Nile don't get bitten by the mosquito is don't go to any of the places where the virus is, especially if you're in a susceptible category like a pregnant female. And obviously, if you make it a piece of advice like that, it has huge economic and political repercussions. And now you have a huge event that's about to occur right in the middle of this area. And there's been tremendous, think about Olympic athletes, think about the age demographic of that. Female athletes, almost all of them, a potential childbearing age. So there's lots of things that people haven't quite grappled with and some conflicting advice. We've tended to be a little more, if you talk to the people at the CDC, don't go, don't get pregnant. You talk to people in some of the countries, they're very afraid of what the economic impact of that kind of advice is going to be. Sorry.
But then taking that and spreading it home to everyone who goes to the Olympics isn't going to.
Right. And remember, but if you think about this, though, despite the way I told it to you, remember, on the whole, for most categories of people, this is an asymptomatic infection, or it's a very mild and self-limited one. Not so good if you're a pregnant female, probably at any stage of pregnancy, and a small risk if it's true of Guillain-Barré and who the hell knows what else. It's a very specific risk group as we currently understand it.
You're a good pathogen if you don't kill your host, but you perpetuate the
Sure. I mean, like everything else, if you eliminated all of your hosts, how do you survive? Now, unfortunately, viruses probably don't have a brain to think about that. It's just the way they've sort of evolved. And killing some of them isn't a big problem.
Ken, we're going to take you out
Oh,
for
yeah,
dinner, so we're going to take and conclude. Thank you again so much.
Yeah, thanks.